People call me Sol. In a moment, I'll be handing over to Professor Deirdre Hollingsworth, who's online. Deirdre is the lead for the NTD Modelling Consortium based at the Big Data Institute at the University of Oxford. And we've had a very productive collaboration with the NTD Modelling Consortium over the last few years to, amongst other things, model the impact of COVID-19 related disruptions. I mentioned this morning that that's only part of the story, that the NTD Modelling Consortium focuses on 7 diseases that we pointed out. The thing I want to say now is just that last week we had a meeting with the NTD Modelling Consortium and other modelers here in Geneva. And we're really happy that we're taking steps now to try and fill the gaps for diseases that have not historically been funded through the NTD Modelling Consortium by interfacing with other modelling groups and trying to create a more comprehensive picture for NTDs overall. Very grateful to the Gates Foundation for the support they give to the NTD Modelling Consortium and for their willingness to kind of entertain that more extended collaboration, which I think will be helpful for all of us. Deirdre, I hope I've brought you enough time to get your slides queued up. I'll hand over to you if you're ready to go. Thank you.
Great, thanks very much, Sol. Can you see my slides and hear me okay?
Yes, perfectly,
Brilliant.
Thank you.
Great. Thank you very much for the opportunity to speak today. As Sol mentioned, I'm speaking on behalf of a larger group of researchers. These are some of the institutions which are currently or have recently been funded under the grant from the Bill and Melinda Gates Foundation, and we also have support from CIF and some other support from the END Fund. As Sol mentioned, we're quite focused by our funders on a small number of diseases, just 7, but I hope some of the things I'm going to present today will be illustrative of what we suspect will be the challenges related to COVID across the diseases. So we have produced some publications in this area. So in March 2020, we produced this report at the top left with an accompanying commentary. We also worked very closely with ESPEN. I'm going to talk about that in a minute to try and provide some of our results for national programs. And we published some of our academic work in a collection of the transactions of the Royal Society of Tropical Medicine and Hygiene. And we're fortunate to have a number of collaborators on that. And then we were fortunate to work with Sol and other colleagues at WHO on providing a report trying to summarize our analyses and their potential implications. And we had some useful discussions in that process about the utility of models in the absence of data, really, to provide insight in this area. So I've got some slides which some of you will have seen before, but I'll just go through them quickly. So if you think about a mass drug administration, at every round of a mass drug administration, we expect to push down the level of infection. And then in between rounds, we may get some level of rebound of infection, but then we push it down again and again and again, and we hope to get down to, for example, the elimination of public health problem thresholds. If we miss one round, then this rebound will continue, but then we can come back with our next round of MDA and continue to push infection down. So any missed round can lead to a delay in achieving the goals, and also an additional burden of infection in those in-between periods. We can try and mitigate this effect, and I think this is the more speculative area of our analyses, because it's very challenging to increase frequency or extent of MDA. But for example, if you were to come back with high coverage and maybe community-wide treatment, when you came back, you would get down faster back towards the goal and could even accelerate achievement of the goal. And you would also have less burden of infection caused by this interruption. So as I mentioned, we tried to work with ESPEN and colleagues there on providing our results, not just these kind of general results saying in general you will see this kind of impact, but allowing people to say in my district with my history of control and an estimate of what we think prevalence is there, what might be the impact of 6 months, 12 months or 18 months delay. And that's a work in progress, so you can go to this link. But that was our first attempt really to try and deliver some of our results for subnational, not decision making per se, but sort of information. So these are just some illustrative results, which are in preparation by Swati Bhattal and Panayota Tulipu, trying to look more closely at our subnational predictions and make them a bit more useful, really. So it's quite challenging statistically to provide subnational predictions, given the amount of data there is available. But the SBEN portal has allowed us to sort of experiment with that and develop some outputs, which we're always open to input on. So here's an example showing the sort of short and long-term impact of an interruption to a schistosomiasis program at the national level. We've just taken an example, the top 10 the top 10 IUs in Uganda and Cote d'Ivoire, which would have the biggest impact of the COVID interruption, looking at the difference between what would have happened without COVID and what happened with COVID. And you can see, and it assumes that after COVID, so it assumes there's 2 missed rounds for COVID, and then you come back strong with a good program. And you can see there's a short-term, quite a large impact, but it declines over time. And obviously the impact will be different in different countries. And this is an example where we're trying to look at where the impact is worse. So this is the prevalence difference for Ascaris at the end of 2021, if the 2020 and the 2021 rounds are missed. You can see it's bigger in some areas than others, but also that it declines over time if the program comes back well. So this is at the end of 2025. For lymphatic filariasis, our analyses and others have suggested that missing a round or 2 may not have a huge impact on lymphatic filariasis. And this is indeed what we see in this plot on the right. That's been shown before in programs. It's quite common for programs to miss a round every so often for lymphatic filariasis. So this is a reassuring result for lymphatic filariasis, and I hope that's what's found on the ground. And just to mention one more thing about mitigation strategies. So one of the areas where mitigation strategies I think have been talked about most is for trachoma. And here we have prevalence of TF over time. We see the COVID interruption, prevalence of TF goes up, and then the program comes back as normal. This is an area where the program's kind of stagnated. And we have a lot of discussion about what might cause a program to stagnate, which I won't include here. But if the program has stagnated and then you have the impact of COVID, if you are able to come back with an enhanced MDA program, then there is the potential to move these areas into achieving their goals. But there's a lot of science to be discussed behind this as to what is really causing the stagnation. For case-finding diseases, unfortunately, there is not so much data available, as I'm sure you're aware. But if we look at this schematic on the right, here's our sort of baseline level of observed incidence. This is perhaps true incidence. This is just a schematic. Once we start good case finding, we start to find more cases, and our true cases and our observed cases start to become more and more similar if we have a good program. So now we've got a good program, but the COVID interruption occurs. So we now are finding less of the cases. We first of all see a drop in cases observed, but in the background, we're seeing this increased incidence. But it might take quite some time for that to be detected, even if our program comes back after a few years. And there's a potential, obviously, for increased deaths as a consequence of that. And I think for diseases like leprosy and visceral leishmaniasis in the Indian subcontinent, for which we work a little bit on, and I think it's true in other diseases, we really don't know how good our case finding is now. And we really don't know what is this hidden burden of infection and potentially death or disability. So I would say for case finding diseases, there's so much uncertainty about the time between you get infected and you appear in the system that it's going to be really challenging to understand what has been the impact of COVID. I think I'll just reiterate some of the summaries from our report. I'll put the link in the chat in a second, but our analysis suggested that schistotrachoma and visceral leishmaniasis in the Indian subcontinent, in high transmission areas in particular, were likely to have the biggest impact of the COVID-19 pandemic. One of the most interesting parts of the report for me was this discussion around how we explain to people that the models are useful but are not necessarily predictive of the exact truth of what's happening. So, and I always find this study very interesting, where they did multiple rounds of MDA in a number of villages, and different villages responded quite differently to the intervention. So our results are intended to sort of guide thinking, but of course there's a lot of local variability. There's a lot of difference in response to MDA rounds, which we can't predict in our predictions. And in particular, when we discuss mediation strategies, most of those have not been tested. And as I say, trachoma is the area where we're having the most active discussion around that. So the potential is for recovery strategies to help get these programs back on track, but it does require quite high levels of coverage, etc. So I mean, I would look to you to see whether that's really likely and whether. But the good news is that if programs come back sort of moderately, for most diseases, over time they will regain the progress they had lost. So one of the things that we've discussed previously is that coming back may be an opportunity for innovation, and I know a lot of you have been involved in delivering that innovation. And our piece of innovation is to try and work with Aspen and others to provide modelling analyses to support these subnational decisions. And I'd welcome your thoughts on our interface and future work, and I'll stop there. Thank you.
Thank you, Deirdre. Do you have any more to say, Sol, or is that so? It's very interesting, and clearly, transmission of these diseases is very different. So, in terms of schisto and trachoma, obviously completely different. So, very interesting. Interested to know what the assumptions were, but I think we haven't got time to go into that just at the moment. Yes, John.
Yeah, I have two comments that are related. One is just, it's great to see that there was such a rapid response by WHO to provide guidance to programs and countries. But what's being done proactively for the next pandemic, which undoubtedly will happen? And, is there guidance on maintaining vaccinated staff, keeping, coming up with alternatives for transport and security, ensuring that maybe we don't have to have as much disruption in the next whatever comes next time, and being a little more proactive. And the second part of that is related, which is that from the report that was shared with a lot of these data, and maybe Deirdre, who's on the line, can comment, it appeared to me that school-based programs were very profoundly affected. And so given that there are many political, economic, and disease-related reasons why schools get disrupted, doesn't it make sense to think about providing guidance around strategies for alternative delivery mechanisms when school is likely to be disrupted? Now, that could be due to pandemics, but it could be to conflict, it could be to other things. It seems to me like providing guidance of when community-wide MDA may be a better alternative than school-based programs could be useful.
Yes, good points, Judd. So, responses from WHO team, ongoing guidance.
Thanks, Judd. They're good comments. I mean, one of the things that makes WHO probably as nervous as anything else is the prospect of being wrong about stuff, giving guidance and being wrong. and the kind of preemptive guidance about the next pandemic is particularly difficult because we don't know what that pandemic will be, what it will look like, how the pathogen will be transmitted. So I suspect that's probably very hard, but the point is well taken. I'll let others comment about the school versus community.
Thank you very much for your presentation. So I just have a question, maybe not a question, but a comment, because we do not just have the NTD. We also have another infectious diseases. And with a country, developing country with very limited resources. So we have our own data here, but it may be difficult for the policymaker make a decision how we should, utilize the resources to improve which program. For example, for the NTD, for the HIV, tuberculosis, hepatitis, etc. We have a lot of burden of disease, maybe impacted by the COVID-19. Is there any indicator or any number that could help us understand which program is heavily damaged by the COVID-19 in all aspects of programmatic and also the transmission? And I think then the country, they might use it data to improve the healthcare system. We want to do everything, but with a very limited resources, we need to identify what we should improve after the outbreak. Thank you.
Yes, so clearly it depends on the disease and the focus on NTD. So is the WHO advice currently that people should carry on as they did before the pandemic? Gautam?
Okay. I think this is where we are actually looking for guidance from the STAG. So, I think the common sense is to get back to where we were pre-pandemic. But I recall a question that Dr. Dhingra asked in the morning was, okay, so by then, if we get back to the pre-pandemic, how much would we have lost? And in terms of transmission, in terms of reaching our goals and milestones that are in the roadmap. And this is where we are looking at the modelers, and this is the reason why we brought all of these sections together, is can the models guide us that these are going to be the implications? Again, it will be vary from disease to disease. But how can we translate all this information back to something very usable and operational at the country level? I mean, we I think I just picked up some of the words that we said in the summary that Deirdre did. In some populations, can we define that some population? In which situations can the program managers say, okay, in Alex's presentation again, he tried to analyze things. Again, it was still at a macro level of the country. If you go down further, you see different scenarios by district level. And program management is decisions are taken at the district level. Can we prepare a guidance, or what do we need to do to prepare that guidance that will help a district level manager to decide, okay, I missed 2 rounds of this or that. So to scale up, what do I need to do apart from getting back to the normal? Okay, because we probably know what also the modeling has shown, even getting back to the normal would mean that we would have missed many things. And they have suggested some solutions which have to be applied in certain situations, because we cannot do increase the number of rounds or increase the frequency. It cannot happen. It's a resource reason, and we don't know whether it is going to be value for money or not. So those are areas that we are looking for guidance from the group. May not be very specific guidance, but what should we as the secretariat do to arrive on that, or or if we have very clear answers that we can provide to the countries based on the evidence we have. So really, this is what is the crux of this discussion of this session. Thanks.
Okay, so it's quite a challenge to come up with recommendations on that. And as you say, we don't really know what the next pandemic will be. But I mean, it seemed from what I saw on the models that, for some of the NTDs, trachoma, for example, if we come back with an enhanced intervention with improved coverage, then we are on track for elimination in a number of countries. And indeed, trachoma elimination targets have been met in, I think, 4 countries in the last 2 years. Is that right? So I guess it depends on the disease and so on, but there are a lot of uncertainties there, clearly. Yes, John?
Sorry, just quickly on that, maybe one concrete thing that we could do would be if WHO could provide the 2030 targets and what would be the impact for each of those diseases likely towards those targets. So in other words, for LF, for example, one would expect that a 18-month delay would lead to a 3%, reduction in the increase in the expected prevalence versus what would have happened, or whatever the models suggest. So to be able to graphically show, in the absence of the pandemic, this is what you might have achieved if you had met all your coverage targets. With the pandemic, this is what you would achieve. And then some mitigation strategies might include, increased coverage by 5% would get you back to baseline or whatever. So for each of those, as opposed to having to do it for each program or each country, just kind of a general sort of, this is the expected gap, and these are the strategies that are likely to make the most difference.
Yes, Jordan.
Yeah. Thanks, everyone. Great presentation. My question, I think, is for Deirdre, although Saul might want to jump in too. Deirdre, some of the slides you just showed, from about 18 months, 2 years ago on the analysis of PCNTDs, and because things like LF and onco have such a low force of infection, or low or not, that you can get away with missing a round, or maybe even 2. Then you talk about the catch up. with 2 rounds of MDA and get right back to where you want, or even improve coverage, you can accelerate what we've just been talking about. But more recently in the last year, you've been doing modeling consortium, and you and your teams have been doing a number of analyses around the never treated. And I'm just wondering how if the never treated are not reached, is it confounded that you could get to accelerated elimination if you don't address the never treated? I'm just trying to really disentangle the more rounds of MDA with the same level of coverage, but no increased reaching of the never treated, versus you really have to reach the never treated, and you weren't going to get there even before there was COVID without addressing the never treated. So if you could just comment on that for us.
Yeah, sure. Thank you, Jordan. Absolutely. If you have a large proportion of, and it doesn't even have to be that big a proportion of the population who you're never treating, then your program was already in trouble, and it'll still be in trouble, even if you are able to increase coverage a bit. So those results are for sort of fairly optimistic results, I would say, for systematic non-compliance, is how we used to call it. But and this is the challenge. So I absolutely agree with what Judd is saying. I think we could probably try and do like a ready reckoner, where you try and say, well, I'm here, and therefore this is what I might need to do. But the problem is, for most programs, we don't really know enough about coverage. And so although we may have had a baseline survey, we may have a few rounds of treatment, we don't necessarily know whether the reported coverage is a fair reflection of what happened on the ground. And so we don't want to be misleading and saying, oh, you're doing fine, you just need to do one extra round, when actually, if coverage is not as good as perhaps is reported, then, as you're saying, if there's a never treat proportion, you're actually not going to be able to get back on track. But I think it's sensible to try and separate the two issues, in the sense that if you don't make progress at your next survey, then you have a large proportion of people who are never treated, that's a problem regardless of COVID, and in fact will make your COVID problems even worse. I don't know if I've really answered the question. Please, Jordan, direct me if I'm off track.
Yeah, I think the never treated, for everyone probably knows, it's people who've missed every single round of MDA. They don't get a single one, and so that seems to be, in your more recent analysis, such a powerful finding, at least for LF and ONCO, that I was just trying to disentangle the potential confounding of the earlier analyses, suggesting that with a little bit more coverage and 2 rounds, you could catch up. But I really wonder if it's really, you got to reach the never treated. And if you can do that in 1 round, you can catch up on what you might have ever lost, with 2 years of COVID. Yeah,
absolutely. And I think it's important to be clear with any of our analyses. When we say increased coverage or twice a year, those are or a new drug, we always say those things will only work if you can get sufficient coverage. So any mitigation strategy or any new tool in an MDA context requires efforts to get to.
I guess what I'm getting at, and now I'm being kind of nerdy about it, but 65% coverage or 70% coverage, if you've still got 20% never treated, but you've got 80% coverage year after year, my impression from more recent analyses is that you're not going to get to the 2030 targets.
And particularly in higher prevalence of things.
Okay, there's a lot of other hands up. I think, Margaret, you were first.
Thank you very much. Thank you, Deirdre, for that presentation. I was wondering, during the pandemic and immediately post, various program managers in different countries did different things to be able to ensure that they met their targets. I would suggest that we have time with them and sit with the program managers in whichever forum that we can get to find out, what did you do, what worked, what did not work, and we can pick lessons from there and use it as guidance moving forward, because they have experienced it. They know what they did to be able to make sure that they delivered their drugs in whichever way and whichever form that they did. Just some suggestions. Thank you.
Yes, good idea. Indiwara, I think you were next.
Thank you, Deirdre, for your wonderful presentation. I'm Indiwari. So it's nice to see that the programs actually will delay their targets but not be really affected by stopping all these interventions with your model. So thank you for very much for presenting that. I just wanted to suggest few things. But if we are achieving the target but not in time, so we can actually either consider our targets in this in pandemic situations like this. If we are facing another pandemics in future, we can consider our targets, and also we can delay our targets if possible. But in our setup, what we did was, now we are in we have eliminated filariasis, and now we are in the post validation surveillance period. But still, with the COVID pandemic and with stopping all the activities during 2 years, it affected us also. So what we achieved from reducing the microfilar rates less than 0.01, it came up with stopping all these interventions. So that really affects. We also experience this upcoming of all these indicators with stopping all the interventions. So what we learned from this is we stopped all the activities and we diverted all our human resources to manage the COVID pandemic. So that was a bad decision that we took that affected, and when we again started to resume duties, it was very hard. So whatever happens, we have to maintain the services at least in a low level, or else we may change our strategies to focus on most hotspots, and we put all our resources, we diverted to hotspots management. Then that actually prevent the resurgence from these hotspots. So those two suggestions I wanted to make, and to consider targets. Thanks.
Okay, thank you. So this is useful feedback from the country level. Yes, Albus.
Thank you. I just wanted to provide some complementary information to what was asked by Judd, by you, sorry, no, about what WHO is doing. So as you know, the World Health Emergency Program, WHO Emergency Program, is certainly working as requested by member states to prepare this new international instrument for pandemic prevention, preparedness, and response. So I think it would be very important, I think if I may suggest, that the STAC, for example, recommends that whatever instrument WHO is going to put in place to address a future pandemic includes also the issue of the continuity of essential health services. We have been struggling during the past couple of years in order to raise our voice and ensure that WHO response was not just limited to addressing the direct health impact of the pandemic, which of course is something that needs to be done, but also to mitigate the disruption caused to health services, which, if they were justified because of COVID-19 was something new, would not be justified during, I think, a future pandemic. So I think it would be very important for WHO to be given the strength to advocate to member states to make sure that whatever instrument or agreement is developed to prepare the world for the next pandemic also includes an important section on continuity of health services, and NTD is part of that. So this would be my suggestion for a possible recommendation. Thank you.
Thank you. There was a hand up down the end there. Yes.
Yes, thank you very much. I'm Fabiana Alves from Drugs for Neglected Diseases Initiative. So the question I have is about the visceral leishmaniasis modeling. So, I mean, all the presentations super interesting, but I understand from the modeling that COVID could have had an impact in the coming period, right, on this transmission that is happening, and possibly some hidden cases that have not turned out yet. So I wanted to know whether you are seeing any of this trend already on the numbers that have been collected from the program over the past months and in the last year. And I understand there is a lot of uncertainty, but until when do you think that these cases could have, start to rise or not seen a decrease as it was happening over the past years?
Thank you. That's a very good question. I don't know if Dr. Sarah Jane is probably there, is he? He would be able to. We had a discussion about this last week, actually, at the leishmaniasis session in the modelling meeting. Is he there? He could probably comment first on what's been seen. Is he online? No. Oh, Daniel.
Sorry,
please.
yeah, I was distracted.
So the question was what's been observed in terms of leishmaniasis resurgence or not, particularly for visceral leishmaniasis, I believe it was. So the models do suggest that we would expect sort of a hidden burden of cases, and it might take us several years to find them, depending on how fast detection comes back. But in the discussion on leishmaniasis last week, I believe Dr. Jain was saying that the cases, VL cases in India certainly seem to be continuing to decline, and the program feels it's probably not missing that many.
Yeah, probably. Okay. So, Fabiana, as you remember, during the World Leash meeting in Colombia in August, also, I had a discussion with the team from Southeast Asia region, and I have asked repeatedly about this. What was the impact of the COVID pandemic for visceral leishmaniasis case detection? Because apparently, that is a region which has shown a steady decline in the number of new cases. So they said the impact was minimum. Partly, one, they did not discontinue the active case detection, so it continued at more or less the same level as it was pre-pandemic period. And other activities also. However, this was expressed by the delay, the observed low delay in detecting patient, in diagnosing patients from onset of symptoms. So that was not long. So some patients who were not able to come during the acute phase, they were able to come later, so causing probably increase in the delay. However, they have continued, and then Saurabh, I remember during the modeling last week, suggested a more active assessment and investigation to ascertain if this is really the case and if cases were not really missed, or substantial, at least substantial number of cases are not missed. Yeah. In other parts of the world, we're not certain. Definitely, there is no similar, active case detection activities in East Africa or Latin America. It has definitely had the impact.
So there are a number of hands up, but I think we're a little bit behind time. So could we save those questions for later and take a 15-minute tea break and then hear some more voices from the field? Okay, welcome back, everyone. So we're looking forward to hearing from the regional NTD focal points and voices from the field, country experiences with regard to use of WHO interim guidance, innovative approaches, field assessments, and lessons learned. So this is exactly what we were saying before to you that we need to hear. So looking forward to it. But I'm not sure who is first.
Afro. Yeah, I'm okay. I'll read from here. Good afternoon, dear colleagues. The first slide is a summary of the overall impact of COVID-19 in the region, and most of the presentations this morning had already given highlights of that. During the pandemic, a questionnaire was sent out to all the 47 member states, and 30 of them responded, out of which 24 had actually cancelled or postponed MDAs as recommended by the HQ, the guidelines. And you will see from the charts in the middle that the most affected activity was postponement of MDAs, and also the reduced or stopped health or community sensitization activities. Next slide, please. Again, this is a summary of the impact. And apart from personal hygiene, which had significantly increased during the period, all the others had slowed down. It's not surprising that personal hygiene had slowed down, had increased, because it was integrated or along the lines of COVID prevention measures, which included hand washing. Next slide. So against this background, during the latter half of the year, when countries, the guidelines, federal guidelines came for countries to gradually resume MDAs wherever possible, a number of countries undertook some initiatives. And here I'm sharing the experience from Guinea. Indeed, there were experiences from at least 4 countries that we invited to share with us during our meeting last month this year in case management diseases in March. But I'm presenting this to show you what happened in Guinea. Guinea combined integrated case management and diseases for preventive chemotherapy. Angola did it for only case management diseases. And so in Guinea here, 38 health districts, nearly all of them is endemic for at least one entity. Next slide. So, and Guinea has a number of community treatment centers, community-based treatment centers with ivermectin, which we're using for onchocerciasis, as well as over 1,900 locally based treatment centers in over 3,000 villages. Using these opportunities or system, they wanted to see how they could gradually resume the integrated activities. Next slide. And the objective was to use those opportunities of mass drug administration to look for leprosy and Borrelia ulcer. Next slide. There was a preparatory phase which involved community sensitization, training of field workers, and enumeration of households. Following which they went out to carry out to implement the activities, and they selected 3 out of the 38 health districts. So these were areas that they didn't have much information about, or did not have much did not have much MDA coverage before then. So they tried it in those 3 health districts. And 1, they used the opportunity to conduct mass drug administration, and then 2, at the same time searching for Borrelia and leprosy ulcer cases. Next slide. So these are some of the findings that came out from their innovative idea. And you see from the bottom, left bottom, that on the average, the red line, pink line, I mean pink block shows that the coverage was over 80% in all the health districts that they visited. And to the right are some of the complications. They did not find any active cases of leprosy and really also at the time, but they found some complications related to leprosy, lymphatic filariasis. Next slide. So in this with this initiative, what were the challenges they faced? They found out that integrating KSH materials or the data collection tools was not easy. And also, integrating finances from the various programs to conduct this activity wasn't easy. This is not new to all of us. We know that it is not very easy because partners or supporting programs have got their own programs, or they have their own targets to meet, and they may not be supportive of this activity. So there was resistance from both the technical staff as well as financial partners, and it was not easy either to involve the local authorities who were just coming out of the COVID pandemic fear, or whatever we want to call it. Of particular difficulty was access to the areas, and this was because of the season that this activity was carried out. Some of them was more or less in the rains. It was towards the just when they were coming out of the rainy season, and it made a lot of areas inaccessible. And then in Guinea, those areas where this is a part of the Sahel, households are very, very scattered, and so it was not easy and quite expensive moving from household to household. But the most important thing was that the village database, they noticed that it was important that the village database must be available before such a combined activity can take place, because active case search is riding on mass drug administration. And mass drug administration, you need to have the database before you can go out and treat. Next slide. So the lessons they learned was that integrating active case management screening activities with PC was effective and efficient, at least in practice. And then the involvement of local authorities was a necessary ingredient to take care of. It was very necessary to involve the local authorities if you want to succeed. And then also, you should have a picture card that has the pictures of all the diseases that you want to integrate and then search for. Here you can see the picture cards of the various leprosy image boxes, but there was they're asking for one that has got all the images of the case management diseases. Here it's limited to borreliosis, ulcer, and leprosy. Next slide. Next slide, please. So pre-implementation sensitization is very essential, is very key. And most importantly, you must look at the economic activities, socioeconomic activities of the population before you implement the integrated case searches with MDA. And also the geographic interest of the programs are also very important. If an area is not, if there's no core endemicity, then it's very difficult to integrate such an activity. Next slide. Of course, the other biggest opportunity was that all along, right from the preparatory to the implementation phase, COVID was in the background, where they had to use the opportunity to sensitize the community members as well as health staff on COVID preventive measures. So what did they recommend? They recommend, there are so many of them, but I highlighted just a few, that WHO should continue to advocate for technical and financial partners to support such integrated activities, because there's a lot to gain from such integration. Next slide. And the conclusion is that Guinea WIN program, the program has initiated or did initiate with the support of WHO a strategy of community-based identification of leprosy and Borrelia ulcer using already existing system, community-based treatment centers for onco, and then other BC diseases in general. This experience has been useful even within the COVID context. There were a number of limitations. Nevertheless, they were able to take all the necessary measures to at least give them the confidence that they can restart their integrated activities even within the COVID context. And they also believe, they also support or conclude that the initiative should encourage, or it could encourage, intervention by technical and financial partners, because this is a question of Ministry of Health and other partners working in those areas. So if such initiatives continue, they will be able to bring everybody on board to ensure that the fight against NTDs is sustained. Next slide. So, no, this is not part of it. Next slide, please. What this has brought out, or what they learned from this exercise, is that can we, given the resistance by financial partners, can we rely on donor funding to be able to integrate our activities? These are just question marks. And then also, closely related to that, we need to continue to advocate for local ownership and funding, so that at their own discretion, they will decide when and how to integrate, depending on geographic and epidemiological considerations. I believe this is the end of it. Next slide. Yes, thank you, and over. These are the pictures of some of the challenges they face.
Thank you very much. That was really, really interesting, really impressive what they did there in Guinea. Who is next?
It's Regional Office for the Americas, so Santiago Nichols, Regional Advisor. Santiago, you have the floor.
Okay, thank you very much. I'm going to present, if Farah helps me with the slides, thank you very much. That would be very great. So I'm just going to present an example because it's impossible to present everything in a short time, but I wanted to present an example of voices from the field regarding the LF elimination program in Guyana. Next, please. So basically, next, please. So this is the story of LF elimination in Guyana. There was a mapping in 2001, and the entire country was considered endemic in 2016 and 2018. I mean, there was not much done between 2001 and 2016. Some actions were done, such as distribution of DEC salt, but other than that, not very much. And between 2016 and 2018, 3 MDA campaigns using DEC and albendazole were done in the highest endemic regions, which were 3, 4, 5, and 10. And in 2019, after some discussion with our colleagues from WHO and other partners, and following the guidelines for the implementation of the triple drug regimen for LF elimination, we decided to implement IDA in 8 regions, 1, 2, 3, 4, 5, 6, 7, and 10, which are considered endemic regions. And in 2021, the second round. Actually, the second round was initially scheduled for 2020, but because of the pandemic and its impact, we decided to postpone it to the first quarter of 2021. Next. So in 2020, as was mentioned before, this guidance was issued by WHO, both including the community-based healthcare and the outreach and campaigns. And also this was, I think, May 2020, and in 27 July, the consideration for implementation of mass treatment, active case funding, and population-based surveys were also published in the context of COVID-19 pandemic. What we did in the first place was that we translated these documents into Spanish and Portuguese, which are essential languages in a region to be able to disseminate all the documents produced by WHO. And we did some seminars. Actually, I think Alvis participated in one or two of these webinars that we did to present to the countries this guidance. So we encourage the countries to follow this guidance carefully. Next, and after the considerations for implementation were published and disseminated, we considered, for example, in the case of Guyana, we considered implementing the second MDA with the triple drug combination, which was initially, as I mentioned, scheduled for 2020. And we followed this flow chart and all the implications that it has. Next. And we considered also all the risk-benefit assessment. Next, please. All the risk-benefit assessment and all the general precautionary measures applicable to designated sites, both for health staff and for the community and for the population targeted. So basically, we decided to postpone the MDA, as mentioned, and we postponed it to the first quarter of 2021. And we did a lot of adaptations to ensure that the safety of the community, healthcare workers, and also of the people in the community. For example, personal protection equipment was purchased. We did training sessions. Training sessions were done for the healthcare workers, distributing the IDA, and on the necessary measures to prevent COVID-19. Instead of doing, for example, the distribution using fixed points or school-based, we did it. It was done home to home, which was more expensive and time-consuming, but we believe that it was the best option given the risk of COVID-19 for the communities and for the healthcare workers. And social mobilization also included not only the issues related to the MDA, but issues related to protection from COVID-19 and to, let's say, to prevent any fears of the community from getting COVID-19 from the community healthcare workers and the drug distributors during the MDA. Next. So this is the graph of the MDA coverage over time. You see that the blue bars, dark blue and light blue, correspond to the last two MDAs with a triple drug combination. And in all regions, a good above the minimum coverage, expected coverage of 65% was achieved in all the 8 endemic regions. Next, and also in this table we show the coverage in 2019 and 2021. And you also see here that coverage was pretty good in terms of percentage of the eligible population in 2021 as compared to 2019. They were basically very comparable with some differences, but overall the coverage was above the 65% threshold of the total population. Sorry. Next. Also, in 2021, last year, at the end of last year, the pre-IDA impact survey, previously known as the pre-TAS, was carried out in 6 of the regions, and this was also done taking into account all the precautions. You see here the healthcare workers and the communities also with their masks and taking all the necessary measures to protect them from COVID-19. Next, and the survey began in November 11 and culminated in December 6. A total of nearly 7,800 people were surveyed across 6 regions and 13 EUs. And this was also a very, very successful survey in terms of reaching the sample size and in terms of also preventing the community from getting COVID-19, following all the recommendations for the community healthcare workers and for the communities. Next. And I think that's okay. This is just the chronogram, the timeline we have for elimination. Actually, we have planned the IDA impact survey to be done in the last quarter of this year, but probably we will postpone it for next year because we have some issues regarding the supplies. Next. And I would like to thank you. Here you see some pictures of the healthcare workers doing the IDA and the surveys with all the proper equipment and necessary supplies for doing both the MDA and the surveys, and ensuring that every precaution was followed. So that's just an example. Some of these similar activities using following the same guidance were also carried out in other countries in the Americas, especially for the MDAs, for STH, for example. But I just want to show this as a good example of how activities can be carried out, both MDA and surveys, even in the midst of the COVID-19 pandemic, taking some important measures to prevent the spread of COVID. Thanks very much.
Thank you very much, Santiago. Do we know the results of that impact survey?
We do know the results. The results were generally very positive. We found evidence that there is no, or that transmission is likely to have been interrupted in Guyana. We are now proceeding to do the IDA impact survey. Jonathan knows well this, but it has been planned. The protocol is complete. Everything is in place, but we are still lacking a few supplies. So we will do it probably in the first quarter of 2023, and not in the last 3 months of 2022. But things are very positive. Look very positive in Guyana, to be honest, so far. Yeah.
That's excellent news. Thank you very much. Very good.
Thank you.
Who is next?
Dr. Supriya from Eastern Mediterranean Regional Office.
Thank you. Can I have the slide? So I will be presenting the impact of COVID-19 in our region. In middle of 2020, like somewhere in June, we wanted to conduct an assessment to assess the country context. So it is a rapid assessment carried out among the 9 high-burden countries, NTD high-burden countries. But the methodology we used was to conducting interviews with semi-structured questions. We mainly use these questionnaires to the WHO country office NTD focal points, but we also want to get the views of the national program managers. And due to that time, the restrictions we had, we could not directly contact them. So what we did, we shared the semi-structured questionnaire earlier with the country focal points, and I requested them to get the responses from the national program manager. So this is the result is a combination of actually it is the views of the national program managers, not of the WHO country office focal points. And then we analyzed and provided the feedback to the countries also. Next, please. So this is the our outcome of this analysis. The questions were structured to assess the context, inputs, processes, and output. So we also we also inquired about get the information on policy, adaptation of WHO interim guidelines. So these are the countries, sorry. The countries were Afghanistan, Djibouti, Iran, Iraq, Pakistan, Somalia, Sudan, Syria, and Yemen. So we got the information on the adaptation of WHO interim guidelines, and we can see that most of the countries had a positive response on thing, and they also said that there's no impact on the adapting the WHO guidelines. And then we assess the staff engagement in COVID-19 response. Diversion of resources to COVID-19 response, the NTD resources, the diversion of allocated funding to COVID-19 response, and the availability of medicines and diagnostics for the programs, because there are a lot of delays in getting the medicines and delivering the diagnostics especially to the field. And then the access to the medicines and diagnostics, training, what happened with the planned training programs, impact on the case management, and the impact on the community-based services, impact on the surveillance, and then finally the output was to assess the reduction in the number of recorded cases. Next, please. So the impact of the COVID-19 on the key NTD interventions. Community-based interventions were affected more than 50%. There's a more than 50% reduction in the community-based interventions. Then the same, similar to the same with the surveillance and reporting. And there's a reduction of nearly 45% reduction in the health facility-based interventions. Next, please. Staff engagement in COVID-19 response was not so bad, because actually most of the time within the country level, we did not, in the country programs, we don't have NTD specific staff. So that is why it was difficult for us to assess the staff engagement, because we have the staff multitasking staff. So maybe that is the reason that we don't see much of a impact on the staff engagement on COVID-19 response. Resource diversion was also not affected, because at the country level, mainly our countries, these 9 countries, the NTD program interventions are supported by the external donor funds, and the donor funds are very specific. So that's why the countries did not have the provision to divert the funds to the COVID-19 response. If they had the domestic funding support, then they could have diverted. But because of this donor funds, they could not do it. That is why we don't see much of an impact of the diversion of funds to the COVID-19 response. Next slide, please. So most impacted interventions are the training, because they could not conduct the training, and then the surveillance. Then the community-based interventions, because also WHO has already presented, the WHO itself recommended to withhold the community-based intervention for some time. But after that, of course, they after risk-benefit analysis to resume them. Then the availability of medicine, because we had a big gap in the availability of medicines. There was very minimum resource diversion and the diversion of the staff. So the barriers to accessing available NTD services during that pandemic was the restrictions, the lockdown measures imposed by the countries, and the travel restrictions they had. Then the patient apprehension, fear of contracting COVID-19 from health facilities. So that's why the people did not come for the get the services, especially for the case management NTDs. And then the public health messaging, the ministry, its ministries of health, or itself discouraged the people accessing healthcare for non-COVID related symptoms. And that is why the people with NTD specific diseases, they also didn't want to access the healthcare to get the services. Next, please. Okay, shall we go? So I have 2 success stories. In spite of all these issues, I have 2 success stories to present. This is one is the conducting mass drug administration to reach elimination targets in Yemen. So once the WHO advised after conducting risk-benefit analysis to countries to resume the mass drug administration, Yemen was one of the first countries which conducted mass drug administration. This is mainly also due to the near expiry of having a near expiry of drugs. And the other thing, Yemen, the mass drug administration programs were supported by the general health funds. So the NTD program was worried that these funds would be diverted to the COVID-19 response. And that's why they wanted to quickly conduct the mass drug administration and utilize the funding. But of course, they used all the precautionary measures you can see in the the photos that most of them are wearing masks and also the gloves, who were engaged in the COVID-19, the mass drug administration. This also built the confidence of the staff themselves, so that they engaged in the mass drug administration without any hesitancy. And also it also built the confidence of the community to receive the services from these the health workers, because they were adhering to the protective measures. Next, please. Yeah. So this is the comparison of the coverage of the mass drug administration I wanted to present during the COVID and the pre-COVID time. So in 2019, they had this mass drug administration targeting elimination of onchocerciasis, and the coverage was 90%. And then early COVID time, April in 2020, also they conducted the mass drug administration. Actually, the countries in our region, especially Yemen, Sudan, they were not affected by COVID at the beginning of the pandemic. Actually, they started affecting the countries, the populations are getting sick with the COVID at the latter part of the year. So that's why the April, Yemen managed to conduct the mass drug administration and reaching a good coverage of 92%. And again in June, they conducted the mass drug administration in 2021, but that is during this time also the country was affected by COVID, but still they managed to get the good coverage of through this mass drug administration. Next, please. In addition to that, in 2020, they also conducted mass drug administration for STH, schistosomiasis, and trachoma, and achieving good coverage. The coverage which I presented within the brackets is the coverage for 2019. But in 2020 also, they almost had the similar coverage as they had for 2019. So this shows that if the community and the health workers work together with a good understanding, they can reach the same, they can achieve the same results, even though in spite of the pandemic. Next, please. Another success story we have in the region is the Pakistan conducting mass drug administration for soil transmitted helminthiasis. Pakistan has to reach about 17 million school-aged children when they conduct the mass drug administration, which they could not achieve even before COVID. So in 2019, when they conducted the mass drug administration, they could reach about 2.9 million, nearly 3 million school-aged children. And 2020, of course, they conducted the mass drug administration. They could reach only about 400,000 children. So 2021, they have to take different methods to increase their coverage to reach their targets. So because Pakistan has a lot of issues with having a lot of drugs expiring and unaccounted medicine. So even we were also demanding a lot of explanations from them. So they have to have they have to use different methods. They have to have different approaches to increase the coverage. So let's see what they did for the increase the coverage. Next, please. They use multiple methods to mobilize the support. They use the existing government structures, and then flexible delivery models and platforms, and community engagement and digital communication to enhance the coverage. Next, please. So what are the governance structures they used? They established a National Steering and Coordination Committee, which monitored the implementation of the mass drug administration. And then in parallel to that, they also established provincial steering committees, which also monitored the situation in the provincial level. And the technical working groups to address the gaps and provide immediate responses when they see the low coverage. And the district management committee at the local, so they use the governance structures to the lowest level to improve the coverage. The next one, next please. they initially in 2019 and 20, they only disseminated the medicine at the school. They did not go to they didn't use the other delivery platforms to disseminate the maybe the salt. But this last year, they used they had a different platforms to distribute the medicine. So not only the school, because most of the time some of the schools were closed, and that's why they had the schools, and then they used the community. They distributed the medicine by house, visiting house to house, and then also they use health facilities, public as well as private sector, to distribute the medicines. Next, please. So school-based interventions were carried out by mainly by teachers. Nearly 75,000 teachers were engaged in this, and health workers were engaged in disseminating medicine. Then the community-based distribution was done by the health workers. More than 52,000 health workers were also engaged in this community-based distribution of medicine. And then the hybrid model, where they were doing by teachers and by health workers, targeting the school children who are enrolled in the school, as also targeting the non-enrolled and children who were not absent on the day of the deworming programs. Next, please. And then also they use the community as also the digital communication to create awareness among the community on the deworming days. So they have more response from the community. They had a huge social media campaign using the Facebook, and then they use celebrities to come and provide TV interviews, to give radio talks, creating awareness and giving the messages on importance of deworming their children. And then also they use the government platforms of the media and TV and radio to disseminate the information and create awareness on the deworming days. Next, please. So this is, and also they use the religious leaders and all they also conducted deworming in the religious schools like madrasas. So these are the some pictures from where they have television interviews with the celebrities and the political leaders. So with all these interventions, they managed to reach nearly 9 million school children. So this is the highest number of school children they reached since 2019. 2019, they managed to reach only around 3 million, and in 2020, only 400,000, and 2021, they reached 8.3 million, more than 8.3 million school children in their deworming campaign. So these are the two success stories I wanted to present, how the countries through different mechanisms reaching their targets to reach the elimination of the NTDs. Thank you.
Thank you very much. Again, really, really impressive. Who's next?
It's Southeast Asia Regional Office. Dr. Ayaya Jima is going to present, and she will share the slides from her. And Aya, you have the floor. And Zaulin, I see also as well.
Thank you. So now from the region, the Sierra, so I first acknowledge the contribution from the country office, especially India, Indonesia, Nepal, Timor-Leste, to share some story on the COVID and plus some innovative activity in this year and the last year. So the first example, so it's not an exhaustive list, but then it's just to share some experience. So in terms of the NTD activities during the COVID pandemic, so Indonesia, for example, the health ministry decree was issued on the IDA implementation by reducing the COVID risk, and then also the DG of the Department of Communicable Disease also published a decree on continuation of the dengue control program in COVID. So this sort of compel the program to continue on the activity in the pandemic. And then, of course, they continue to have a hybrid program evaluation meeting or LF training of the stakeholders or program sensitization for World Leprosy Days, etc. So they continue on the activity, if possible, through the hybrid mode. Then also India, so that there was the involvement of ASHA. ASHA is a female community health volunteer known as the accredited social health activities. And they are available for every 1,000 population at the village throughout the country. So the ASHA has been especially engaged in community outreach activity for NTD during the COVID-19. So for example, the left side is a house-to-house case search for the Karaza activity by ASHA in a village during the COVID pandemic. And also the right picture is a house-to-house drug distribution for ASHA for LFMDA. So you can see that the ASHA tried to keep some distance and while ensuring the drug distribution to the community house-to-house. Then also I wanted to share some of the innovation, not necessarily related to COVID pandemic, but implemented in the last 1 or 2 years. So one example is Timor-Leste. So they implemented the LF task, the first transmission assessment survey in the end of last year, and they integrated the survey for STH, YOS, scabies. So they combined this for disease screening together. And I'm not going to go into the detail, but then for LF, task, they have divided the country and the nationwide into the 7 evaluation units. And then during in each evaluation unit, so this is the STH component. So the school children were sampled and then school students samples were collected for STH survey. And for LF, so all EU passed. And then for STH, so they were able to estimate the prevalence both by any disease or by species at every evaluation unit. And also the older children who participated in the transmission assessment survey was screened for scabies and YOS. And then any suspected cases with YOS-like lesion was confirmed with a rapid test and also scabies as well. So this was a successful integration of the multiple disease through the LF survey as a platform. And they're planning to do the similar survey in the next year. Then another attempt to improve the MTA coverage was from India. So in India, thanks to the support from the BMGF, so we have NTD, what we call NTD coordinator at state and district level in the priority state and district. But even they are not enough hands to to monitor all the MDA activities. So they have employed the local medical school students to be the external monitor for MDA and MNE activities. So they were recruited and trained, and they go out during the MDA campaign or MNE activities to monitor how the activity is being done as an external monitor, and then so they can ensure that the MDA compliance as well as the proper implementation of the MDA. Also, Nepal, this was the first year that they initiated rollout of the IDA, the triple drug therapy for MDA. So they have tried their best to improve their implementation. For example, they organized for the first time the national level strategic planning meeting involving all the provincial stakeholders and micro planning together. So before, the MDA planning was more like top-down sort of approach from the central level, but this time the state level, the provincial level focal point were well engaged and then took the ownership for the micro planning. And also they developed a series of advocacy video in the local languages about LFMDA, including even the video with the local comedians, and also intensive monitoring and supervision. And for the first time, they also adopted the height-based loss score for implementation of the IDA. Then another innovation was in Nepal was supported by us as WHCRO for the first integrated field entomology training. So the lack of the entomologist at the country level is quite a significant challenges in all the CRO countries at this moment. And so the idea was to train the vector, not only vector control officers, but also the public health officers and lab technicians from all the provinces on the basic field entomology so that they can understand all the Aedes mosquito, Anopheles, Culex, Mansonia, and even sandfly of the basic of the biology and transmission and dynamics and how to do the sampling, how to do the vector control for every aspect. And then there was a lot of field work to roll out to practice the vector control sampling and the vector control planning in the field. So this was the first attempt, and we hope to do this in every country. And also we are organizing now the similar regional training in November, and hope to have this training rolled out every year. That was it from the Sierra country. Thank you.
Thank you very much. Very interesting. Is it Wipro? Wipro next?
Dr. Tip from Country Office Vietnam will be presenting on behalf of the region.
Good afternoon. My name is Tipawan, Technical Officer from Lao Country Office. So I would like to share the experience to implement the NTD activities during COVID-19. Next slide, please. In Lao, MOH focus on 6 NTDs like LF, Cysto, STH, FBT, and rabies, and dengue. For LF, we already submitted a dossier for verification as of public health problem. And for Cysto and STH, we implement the MDA more than 10 years now. The prevalent infection is reduced a lot. For FBT and rabies and dengue are still big challenges for us because of limited resource. Next slide, please. For COVID-19 situation in Laos as of 25th September, we have around 200,000 cases, reported cases, including 600 days. And also most of the cases were reported from all provinces across the country. And currently, we receive a very small number of reported cases, like 10 to 20 cases per day. Next slide, please. Before COVID-19, we also implement many activities to control the NTDs. For example, like for Cysto MDA, health center staff are the one who provide the medicine to the least group in endemic areas in specific point like a temple or village head office. And also for school deworming activities, we also implement at the school by school teachers. And also before we implement the MDA, we also conduct the training or briefing for the outreach team before before conducting MDAs. And also every year we will conduct the World Rabies Day celebration with we gathering a lot of people, like more than 200 people for raise awareness. Next slide, please. And during the COVID-19, with the MOH support, and also we have an ad hoc committee that released the notification for control measure like not gathering people more than 20 to 50 people, and also very strict for travel. And also we have school closed. Therefore, it's also impact to the NTD program. For example, like Cysto MDA, we have to, with the strong support or leadership from the MOH, we change the strategy to implement the activity. Like in the past, we gathering many people in one specific point, but now the health staff have to go and visit it household by household, which will take a long time from the before the COVID-19. Like we implement only 1 month, but now extend to 3 months to complete the activities. And unfortunately, we cannot implement the school deworming program because of the school closed. And for the training, we also can conduct it small group of people because of the not around 20 to 50 people to attend the training. And also we cannot do the distance training because of also is new technology for the staff at the provincial and district level. And for the World Rabies Day celebration, we also changed the strategy. We just conducted the small medias to provide the information to the journalists, and then they can help to disseminate the information to the public. And also we can post to the Facebook. So next, please. For the lesson learned during the COVID-19, many activity, we found that many activity was postponed, particularly related to the mass gathering, like a training to implement the school deworming or integrated information for rabies into a teaching curriculum. This is also one health approach that we are implementing in the country level. And also school age children could not receive their medicine because of the school closed almost 2 years. And also we lost the opportunity to receive some fund, particularly for the STH training after we had the experience of severe adverse event in 2020. So MOH also would like to revise the guideline and also provide the training to the key staff at the ground levels. Even though many activity was not postponed, but we also can implement some activity which not specific for the mass gathering, like a student examination for sister at the Sentinel site. And also we learned that we also have a good opportunity to think and change the strategic or mentor to implement the activity like SDH, MDS, and also World Rabies Day celebration. Thank you.
Thank you. Very nice. Interesting. Is that?
Yeah.
That's it?
Yeah.
Okay,
Yes.
so I guess the floor is open for questions and discussion. There were some questions left over from the previous session. Lucille, I believe you had one.
Yes, really good presentations and innovations, I think. So we've spoken about some of the challenges to the program during COVID, and obviously these lessons need to be transferred to other emergencies. We may not have pandemics, but we have a lot of emergencies in countries. We have earthquakes and flooding and other outbreaks. So I think we need to really use what we learned during pandemic to include an emergency response for NTDs for other emergencies. And I think we've outlined many of the things. But we need to harness many of the successes of the COVID-19 response. So one of them speaks to laboratories and the innovation about rapid tests. The other speaks to the sequencing networks that have been set up, which is really important as you reach elimination to describe the epidemiology. There's a lot of new capacity that's been built, data collection systems, WASH initiatives, and even vaccines. I mean, we've been struggling with dengue for years, but I think those are some of the areas we can look at and recommend.
Absolutely, and point of care diagnostics. Everybody knows what a lateral flow assay is now, don't they?
Yeah, do them at home.
Yeah.
Thank you. Great presentations, and I'm actually going to echo what Lucille just said. One thing in terms of lessons learned, at least what we have learned directly, is related to the guinea worm eradication program during COVID-19. Contrary to interruption of MDAs, by virtue of the fact that the Carter Center works directly with the communities and working with the community health workers who reside in the communities, we did not see any kind of disruption in the guinea worm eradication program, which was pretty incredible because when the numbers were coming in terms of decline in the number of cases, both human cases and the animal infections, my biggest fear was that are we actually looking hard enough? Are we doing the surveillance that needs to be done? And but to my pleasant surprise, the good thing was that the community event-based surveillance and the rumor generation, in terms of rumored cases, when we looked at and did the analysis compared to pre-COVID, it was actually at the same level and in some cases higher in terms of the signals that were coming in. So I just think that, yes, I mean, there were interruptions in MDAs. Some of them could have been, some of them were probably by the country's own choice. Some of them were probably driven by the administrative direction by maybe WHO. But I think at least in guinea worm,
we actually had a very different experience. So this is something that I think, as we capture some of the lessons learned in terms of the successes and some of the challenges, working directly with the communities and having that trust with the communities it really paid us off.
Thank you very much. Excellent thoughts for action, and a lot of good work being done as we learned from the regional offices. But I would like to raise two issues. Number one is, as a part of the preparedness, we have the health emergency division who are responsible for predicting and asking the system to prepare for these type of things which we have been discussing. COVID-19 is an example, but what has been said for earthquake or for other problems, there also the NTD interventions got disrupted. So my suggestion is that that sort of coordination with the health emergency wing would be useful. Second, for surveillance, for particularly the communicable diseases, and the system which is in place, like for rapid response team and other things, also maybe an additional force to the NTD constituency to take forward the problems. Thank you.
Yes, Wendy.
One of the big change was on personal hygiene and the WASH program, definitely. And do we have is there any way we can measure the impact of that, the WASH program, or the speed over to the trachoma and the stage control? And the other thing is, especially with the WASH program, it was in the health system, it has in my country, it has brought a lot of changes in bringing the WASH materials and so on. Can we take that lesson into the schools now? Because the schools at that time was closed. So the WASH improvement in health institution, can that be also translated to schools?
Yes, very good point about WASH. Naseem.
Okay, I just want to reiterate what Lucille just said about outbreaks in floods and natural calamities. Right now, as we speak, there's massive flooding in Pakistan and parts of Pakistan, and there are massive outbreaks of dengue and malaria, even amongst pregnant women who are dying. Babies are dying of cholera, dengue, malaria. I think this is the time that NTD, WHO has to pay attention to the diagnostics and some kind of a support. I just thought I'd bring this in. In my hospital, every single day in the last week, 200 people come up with fevers and 50% are diagnosed with dengue. So I think this is the right time to pay attention to this kind of a, I don't know how to call it an outbreak, but it is just incredible. Thank
you. Thank you. Yes.
Thank you. Thank you so much. I have been listening quite patiently and just wanted to summarize some of the lessons learned from COVID, which we can utilize as we move forward. And this is something we have been discussing with our outbreak team, with our research team in TDR, and with vaccine research and others. So first of all, on diagnostics, we are now left with a large pool of PCR equipments all over the country. So how are we going to utilize them? So there is an opportunity here to enhance diagnosis in countries where these PCR equipments post-COVID can be easily converted. And we are also discussing with some manufacturers on how this can be used for enhancing, for example, arboviral surveillance. Surveillance of malaria, for example, as they move towards elimination. And certainly the diagnostics of NTD, where PCR is a gold standard, we have an opportunity here. The second issue here is we are also conducting a network of lab survey in all regions of WHO as part of strengthening arboviruses in post-COVID era. And this network of labs would further help in training and building capacity in countries where they are lacking. And there is I must admit, there is a focus on Africa because arboviruses are creeping up in Africa. And if you have listened to the regional committee meeting in Africa, which was held about a couple of weeks ago, there was more than 200,000 dengue cases during 2020 alone. And so irrespective of COVID being rampant in 2020, 2021, dengue cases and many other communicable diseases continued, and they were there. And unfortunately, there are countries, including my own, where dengue patients were not allowed because all the hospital beds were occupied, and a few of them died. It was reported in the media. So the other issue is we have got a good opportunity to look into community-based interventions in more closer way, because very often I've been questioned, what is WHO doing in terms of community empowerment? Because we had an example of COMBI, Communication for Behavioral Impacts, about till 2012, and there were documents produced on it. So we are getting more and more questions. Okay, what do we do with this? How do we utilize community? And there are examples where community health workers covered for preventive services like dengue control. For example, in few countries in Asia, community health workers were relied on to make sure that breeding was controlled in and around houses. Families were encouraged to remove the breeding sites. So because you are already on lockdown, but it's a good chance to clean up your environment. The vaccine, what Lucille said, yes, there's an opportunity there. Work is in progress. There's a lot of discussion on harmonizing vaccination, and especially with the yellow fever being rampant in 12 African countries right now, we still have more lessons to learn. So there's a lot of wealth of information post-COVID, which we can tap on to improve diagnostics, surveillance, and community-based interventions. Thank you.
Thank you, Rahman. Yes, very good points. Emily.
I've been listening to the conversation and thinking about the question of, what is the take home message and we can learn from COVID. And I do want to acknowledge that I appreciate that WHO went to the time and effort to try to do these analysis. And I think one, I would say, is a second step that they need to be further unpacked. There's a lot of noise in that kind of data when it's rolled up at the global level. And so just looking at the country examples, the FCDO cuts are reflected in that. And we're talking about them as a COVID response, and they're not a COVID response. That's a withdrawal of donor funding. So that creates noise. I think there's some progress that was in those numbers, and that may not necessarily be reflected. So I think it's worth taking a look at that. I think the other thing to notice I thought was very fascinating on the one page, the one slide that Alexi showed, actually the variation from region to region about what happened. I think we need to remember countries stopped the work because WHO issued a policy. That policy approach was not taken in maternal and child health. It was not taken in family planning. It was not taken in malaria. And so how the regions responded is very different and reflected in the response. USAID, we got caught in the crossfire of West Africa that promptly pushed back and said, we are not going to stop and you need to help us figure out how to move forward. That's reflected in that data. But I think it drives us down towards what we're hearing in the room is what can we learn at the country level? And what those countries did was sit down at the table. The silver lining in the pandemic was NTDs got invited to those cross-sectoral discussions about how are we going to fight the pandemic. And that's where they had the opportunities to work and contribute to other interventions about, like, do we switch to door-to-door platforms? How do we think about infection control in the outreach measures? And I think some very successful things happen. And I think to the experience in country, even the room, the amazing examples in the room, there's even more. Like Guinea's a great story, but Guinea's success is also based on what they learned because of Ebola. And that's a direct reflection of that. And so I think it's just kind of this, there's these broad trends, but really going down and figuring out what countries have done at the level, because I think the regional examples show it's very sophisticated and country specific. And I think there are things that we can learn and pull that up. But I think we need to kind of go to that deeper level, country by country. But as you can see, even within the country, the disease variation of the implications of something that you can take to someone's door versus the implications for diseases that are addressed at the facility level. And so I think there's kind of that next level, because I think there are things we can learn if we want to look into the future and say, well, what happens when the next disaster shows up? And I think NTDs is an amazing area that day to day, not just in a disease crisis, NTD programming happens in conflict settings all the time, and the strategies that are there, I think that's just a whole nother area of learning that can be brought up and shared, not just within NTDs, but the larger global health space.
Mr. Chair,
Sorry.
there are two
Yes,
people
Susanna
online.
Vasnieri. Susanna, I'm sorry you asked some questions this morning that were not answered. And it must be rather late at night where you are now. So over to you.
Thank you. I'm still awake barely, but it's very interesting. So it's not possible to sleep, actually. I do have a few comments on this discussion of, impact of COVID-19 on implementation of NTD control programs, and maybe a few observations. So, and kind of linking to other comments that have been made. I'm very pleasantly surprised to see that in many of the country examples that were shown just now, there seemed to be a pretty high coverage, MDA coverage, even after COVID hit and after activities resumed. Maybe there's just an anecdotal sort of evidence, but I believe there is some evidence in some countries that not so much the impact of COVID-19, but actually the impact of the rollout of COVID-19 vaccination may have had a negative impact on MDA acceptability and coverage. So I'm just sort of kind of raising that issue and asking others in the room and in countries whether they've had similar experiences and whether this is something that is worth looking at, not only from the field perspective, but also feeding back to the modeling exercise that the modeling exercises that are taking place, given that the models that Deirdre showed kind of assume a going back to normal or even improving or increasing MDA coverage. And I'm wondering whether the models could or should also take in consideration the fact that maybe MDA acceptability may be decreased in some countries. Kind of linked to that is a bit kind of complementing what Emily just said, and also Judd's comments in terms of what happens in the next pandemic. I guess, different countries, when those WHO guidelines and guidance that were very useful and I guess needed were issued, I think, I wonder if in the future they could be a bit more tailored to different contexts, because I guess while in Africa and other parts of the world, I mean, COVID-19 hit different countries and different parts of the world at different chronological stages. So when there were guidelines to stop MDA, for instance, in the Pacific, there was no COVID because we just closed the borders and that's it, right? So basically, the request to stop MDA may or not have been aligned with the context that the countries were experiencing at that time. And also conversely, when other parts of the world were recovering from COVID, that's when COVID finally got to the Pacific, and then countries had to sort of catch up with all those measures. So yes, I guess maybe in the future it would be useful to consider sort of different responses according to the context. Thank you.
Yes, thank you very much, Susanna. Neeraj Dhingra, you are next, I think.
No, thank you. I think many points have already been said. I think we do realize that COVID did cause disruptions, and how those disruptions are going to affect in the longer term. Some projections have been given by the modeling. Now, this modeling, we may have problems. I understand there may be a lot of noise on the methodology and others. But anyway, the issue is there has been disruption in the services. And this disruption has to be overcome in the coming days, for which it is very important that the advocacy, especially with the funders, especially with the implementers, especially with the country leadership, has to continue, and this has to come strongly from WHO. That's one. Second is, COVID has provided certain opportunities. Some of them were already mentioned, for example, the PCR labs and others. Also, COVID has done a lot of health system infrastructure improvements in all areas. Now, this infrastructure improvement has happened, and I think entities need to exploit that. I think HIV, TB, hepatitis, other programs will be competing with entities, and that's a problem where entities have to come out very strongly on this aspect. Lastly is, in COVID, IT did show that it can play a major role, especially in surveillance and also follow-up of cases. Now, this is the place where we can look into how we can do it, use the IT to the maximum possible extent, especially in cases where the cases are going down. Can this be used for tracking, surveillance, and even follow-up? So that may be a great help. Even, we did see applications being used, and they can be used even for MDA monitoring. Thank you.
Thank you, Neeraj. Aya Yajima, I think you have your hand up.
Yeah, thank you. I just wanted to add a few points, maybe following what Emily mentioned, also Susanna mentioned. So this is across the Asian and Pacific, because until last year I was in Wipro and then now in Seattle, and I see the country situation really different on the impact of the COVID. And then what I could really observe is that the country which has a very strong capacity to implement activities, then even if the border is closed, then they can push on. But then if the country is really relying on the partners, then the partner could not come and support, then the activity delay. So even within the Pacific Island country, I see the major difference in this depending on the country capacity. And then also another thing is that Susanna mentioned, when the COVID vaccine, even the COVID is not serious, but when the vaccine campaign started, then it really how much voice the NTD program manager has within the ministry, because they have to compete with other programs to get the space among the COVID vaccination campaign. So again, this really changed the speed of the NTD activity coming back to the power. So that's one thing I wanted to mention. And another thing I forgot to mention, maybe in my presentation from Seattle, is one of the major impact also we had due to the COVID is the drug supply and the logistic shipment. It's in a different way in a big country than small country. In a big country, because of course the donation of the amount of the drug donation is also huge. Then they require a huge amount of the space. But then space is completely taken by the COVID response, all the supplies. Then there was so much energy and time spent. I'm sure the AHA teams can share, and then also the country office team, so much energy to move around and what to do with the space. Then also the small country, then they lost, especially the island country, but not only the island country. Many small countries didn't have enough flights, ship to get the medicine coming into the country. So again, we had a lot of all three levels of WHO really struggle to get the supply into the country. So this is something that I think we should be prepared in the next whatever pandemic or whatever, that we have to find a better way to manage it. Thank you.
Thank you. I think you were next.
Yeah, I want to make some comment on Mr. Raman's, Dr. Raman's comment. And you said that we can convert all the PCR machines to other programs. The problem is now in Sri Lanka also we have a lot of PCR machines which we can use, and we were given also, but it's very difficult for us to have these reagents. Now in the reagents all the primers are okay, but the DNA extraction is very costly. So if we can explore other ways to have low cost DNA extraction methods, then we can use all these machines for our purposes. If not, it's very difficult, because for COVID there were special funding and special allocations, and all the funds were dumped into to control the pandemic. But for NTD programs and other programs, they will not do the same, and there will be problems in acquiring all these reagents, especially the DNA extraction kits. And also, as you mentioned, the combi methods that you told about this dengue during it has affected the dengue program. So for us also, COVID became a blessing for dengue program. Actually, during that year, I was working in a district as a technical manager, and it was the most highest risk district for dengue as well as for lymphatic filariasis, that is in Galle. So during that 2021, we didn't get a single case death due to dengue during 2021 in Galle. So that was a really good achievement, because all the people were at home and they were cleaning their surrounding, and it was a blessing for the dengue. Also for rabies also, there were less dog bites, and there were it was controlled because people were confined to their houses. And also I also want to thank WHO for prioritizing healthcare workers in vaccination, COVID vaccination. That also affected to continue, that was helped to continue all the healthcare. Some countries, they show that they did not, the NTD programs were not affected, the service delivery was not affected due to COVID. That is because we were prioritized, and we were given, and we gave the assurance and the recognition, and it helped a lot to continue all these programs. And I would suggest that pooling all these experience, we should have a preparedness plan for the next pandemic, to prepare for the next pandemic, and to have a to smooth implementation of all these NTD activities, especially for NTDs, we should have a preparedness plan. Thanks.
Yes, absolutely. I think we have somebody else on Ahmed Abdul Wahid. Yes, Ahmed.
Yeah, hello. So thanks. I think I would exactly confirm what our Sri Lankan colleague had just said, that the problem nowadays is not having the machines, because the machines is everywhere. The problem that we need to have local production. This is a very big problem faced not only in Asia but also in African countries, that they have machines, but reagent delivery taking either too much due to all the crisis we are facing now. It's getting too expensive. So I think we need to stress in the coming phase that the local production in countries most affected with the stuff must be strengthened in the future. That's what I would like to comment.
Thank you, Ahmed. Yes, Li Ching.
Hi, I just want to echo some of the lessons learned from COVID. I think COVID has forced us to do things very differently. Really, we used to do many things and the same for many years, but because of COVID. One example I would say is intersectoral collaboration. I don't think any country fought dengue with one agency or one sector. It's all been collaborations and intersectoral. So I think that this friendship network made during COVID is really a nice platform. I personally experienced that as we fought COVID. I make friends in different ministries. And I think this should be leveraged for NTDs like dengue, which really requires multi-sectoral collaboration. And the strength of COVID in reaching out to the community, I think many testaments to that. We talk about social mobilization, and it has been very successful with COVID. Everybody knows COVID, and so I think it's something that that network, whether it's community leaders or churches or a religious group that we have relied on COVID, should be sort of built on and use it for other diseases. One other aspect that we use a lot is social media. I think Supriya from Emerald described how Pakistan used social media, and we were also forced to do that because we had COVID and dengue outbreak together, but we couldn't go out to do our outreach. And so social media became a main form, and up to today, I think it's a good platform to use. So just want to say that these platforms that have been built during COVID, we should really leverage and use them. Thanks.
Yes, thank you. Sol, I think you had your hand.
Thanks, David. I just wanted to respond to a couple of the points that people made about modeling. Deirdre mentioned this very briefly earlier, but she talked about a lot of stuff and perhaps didn't highlight this enough. One of the things that the NTD Modeling Consortium has done over the last year or so is to develop a thing that they call the interface, specifically for countries in the WHO African region, which takes data from ESPEN and applies models on a district level basis and allows the user of the system to modify the parameters, so coverage, for example, and produce a prediction as to what the impact will be of resuming interventions, given baseline prevalence, previous intervention history, and future interventions. Clearly, that's something that you need to take with a grain of salt because it's an individual level prediction for something where averages mean a lot more than individual predictions, but it's there and it's something that people can look at.
Yes, thanks all. There was one up here, Kashif. Yes.
Okay, this is my first STAG meeting and I'm thoroughly enjoying it. I mean, I'm not a member of STAG, but as a partner, I am. So thank you very much for inviting us and actually having this open session. That's first. I want to sort of circle back to the comment made earlier about humanitarian disasters and the continuity of care and NTDs. And I mean, as was pointed out, when there are earthquakes or floods and things like that, and when there are internally displaced population, so some of these populations might be at risk of NTDs or might be coming from communities that are endemic for various NTDs. So has there been, and this is part of my ignorance, and apologize, has there been a discussion by the STAG members? They tend to be very technical, which is rightly so, but this is also a technical / programmatic area, I feel, that needs to be attended to. So I'm just putting out a suggestion. If it has been discussed before, that's great. If it has not, then
so I missed that. What was the issue?
The issue is that when you're looking at continuity of care for populations that are internally displaced as a result of an humanitarian disaster like floods or earthquakes, what does the NTD program do working with, let's say, the health emergencies program? And how do they collaborate? And how, I mean, there's another layer, which is actually at the regional office level, working with the country office where the disaster might be. So I'm just throwing it out as a topic.
So it was something that was discussed last time, I believe, and we did suggest there was a need to consider NTDs in displaced populations. I'm not sure what progress has been made. Okay.
Thank you. I just want to make a couple of comments on this specific thing. We have been collaborating on documents for refugees and migrants' health, and we have ensured that NTDs are there. So in principle, they are covered. Now, with regard to the issue of WHO guidance on COVID-19 that has been raised by you and also by Emily and by Susanna. So first of all, the initial recommendation to postpone or to suspend community-based intervention did not apply, for example, to surveillance for COVID-19. It was mainly limited to mass drug administration and other intervention that could be characterized as mass gatherings and therefore as being associated with a higher risk of transmission of COVID-19. Perhaps it was a hasty decision, but as I understand, some of you have this opinion. But you may also recall that already a couple of months, 1 month later, actually in May, the detailed guidance on community-based interventions already made provision for a regular assessment of the situation through a risk-based assessment, and the guidance published on the 27th of July really provided the tools for the resumption of community-based intervention. So in fact, this suspension lasted more or less 1 month in terms of guidance, and of course it had maybe longer-term impact. And to come up with to comment on what Susanna was saying about the tailoring of the guidance, the guidance published on the 27th of July, of course, was based on risk consideration. So I think it allowed for the tailoring of the decision to the different epidemiological situations. So of course, if the country was a country where SARS was not an issue, then of course the intervention could go ahead. So it allowed for some sort of tailoring to geographical context or to different transmission scenario with regard to SARS-CoV-2. So I think this kind of consideration, of course, were not initially taken into account perhaps on the 1st of April, but were then taken into consideration by later guidance. Thank you.
Yeah, I think one additional, 2 points I want to make. One additional consideration, I think, with the modeling, which is fantastic, and I think can really help programs, because I think the outputs of those models are useful at the programmatic level. But at the political decision-making level, I'm not so sure that's how political decisions are being made. And I think incorporating some costing and financial modeling on top of that, layering that, a lot of countries spent an enormous amount of resources on COVID and actually didn't have a whole lot of, vaccine uptake wasn't great. Even, social isolation and masking in some settings wasn't great. So what was the actual expenditure versus, actually what happened in different settings? And what was the cost to the NTD programs of not putting that money in the NTD programs? Just to give, because I think at the political level, that's really how decisions are made. And I think it would be very interesting to see. And also just to add to that, I think the re-implementation of programs, as we're hearing, is complex and expensive. And so what does it cost to re-implement? So that was one point, is just to include maybe some financial modeling in that. The second point, I think, is that there's been a lot of media and I think recognition that the health workforce around the world has been incredibly burdened by COVID, not just, in terms of work, but just burnout and mental health issues. But I think NTD programs are unique in the fact that there's an enormous cadre of volunteer workforce, the drug distributors and all of this, who were very impacted, and many of whom have been part of these amazing stories we just heard about. And is there a role that WHO can play in recognizing that and in supporting them to share, this is amazing what you've been able to come back and do, because I don't think they're formally acknowledged in a lot of other ways. So those are my 2 comments.
Gautam, your hand is up.
Yeah. Can you use the microphone, please?
Sorry. Okay, so I think it has been a lot of very rich discussion on these. I think if I try to break it down, I think one aspect was lessons learned from the recovery phase, how countries are adapting to the COVID situation and still increasing their coverage and services for NTDs. The second one was, how do we use these experience to prevent during future ones? I think those are 2 very important ones and to be captured. But I want to bring back the stack to my original, and that was one idea which is that we had when we placed this this in this particular stag discussion. Okay, let me put it a little blunt way. Is the stag concerned with the disruptions that we have tried to show? There are limitations, as Emily brought in. I mean, we showed at a more macro level, but if you recall, Alex, he also went country by country in some situations, and he has shown the data is there. We can, all of you can go and look into that. And also, maybe there is going to be within the country the difference between different areas. We also heard some of the confounding factors which might have played, FCDO, cessation of funding. But I think there are many countries beyond that FCDO funding which were also affected. We also heard things like, the ones which had stronger health system probably were more resilient than the ones which were totally externally dependent. But the question coming back to the stag is the stag concerned with this, so that there is a message, a guidance to us that we're looking forward, that look, maybe you need to do this and that before we can come up with some recommendation, or you need to work with the modelers to get these answers. Or maybe we are not so bothered, just get up to the pre-2019 levels, and if the milestones and targets are delayed by something, so be it, we are not bothered. I mean, it's the two different stark sides. But I think if the stag could give, this was my expectation, that if we could get some guidance from the stag in this direction, that apart from the lessons learned and the future, what, based on the current disruptions we are seeing, and do we need to do some mitigations in some situations, like where the modelers might, even it may be still based on many assumptions, but again, can we draw some conclusion that in some situations maybe we should recommend additional round, more frequent rounds in these situations, or some other activity? So that's an area that I want to still think I would like to bring the stag back and seek their guidance on it, which could be anything that you think is proper.
Thank you, Gautam. I think we better think about that overnight. That's rather a difficult one to answer in a few minutes. We have a few more. Yes, Li Ching.
Yeah, can I just comment, because I think it's different for different diseases, right? So it's very generic, because the model only showed one aspect of NTD, but there are so many others like dengue and all that. So I think it's very difficult for STAG to make any recommendation, because I think it's very specific. It could be specific to diseases. And so I wanted to bring back to Vukwat's point on how do we compromise? What is there a guidance for countries to say, under this kind of circumstances, what should we compromise and what should we not compromise?
No, precisely. I mean, those are the points.
Microphone, please.
One-line answer to solve.
Got the microphone.
Yeah, so not a one-line answer to solve everything, but I think those are the things that would be very useful for us as the Secretariat to take forward, that, okay, this is what the STAG, I mean, you are the collective expertise across health systems, NTDs and others, to tell us, look, we can't give you an answer for this, but this is an area that you need to look forward in the next 2 years to see how we can come back on these diseases. These has a higher potential of being affected, these less, or I mean, something that would be very useful to us. I mean, if we can't, that's fair enough, but okay. Yes.
So I was sorry. I was just going to comment. This might be a little bit presumptuous, but I mean, I do worry a little bit that if we were to come back with very direct guidance on, you should do X, Y, and Z, even for disease specific, that it fails to recognize the fact that, most countries are really struggling with the pandemic in the broader context across an entire health system. And I think, that's why I felt earlier the idea of using those models to say, we expect that you might expect this sort of an impact from the pandemic, and some mitigation strategies would include increasing coverage, whatever, and giving the options to countries. But I think if my own feeling is if the STAG were to recommend and then WHO were to say, you should, double down and increase frequency to 3 times a year, it just seems hard because everybody's struggling across all disease states to how to deal post-pandemic. And it just seems a little bit presumptuous. So that's my 2 cents.
Sorry, if I may, precisely the point that you don't have to make a very specific recommendation. I'm not trying to force you to make one specific recommendations, but as you said, maybe the models, this is what the modelers need to do in the next steps, that that could be very useful. This is what the secretariat needs to do with get more data at the district level that we want to see. So some of those kind of things, and when I say recommendation, doesn't mean that you are going to give us one magic bullet, and definitely with we are very careful with our guidance to the countries that this has to be very evidence based, not just that this is what we think and we put it on the shoulders. So that's precisely what I'm looking at. Thanks.
Thank you. Yes, Jordan.
Yeah, thank you. I want to get back to some of the laboratory issues that were raised earlier and the benefits that came out of COVID. I think we've been talking quite a bit about the opportunities of leveraging the NTD platform for emergency response and those kind of things, but we should also be leveraging the pandemic preparedness platform for some of the work that we will need to do in NTDs. And one of the things that we saw over the last couple of years was just a robust increase in serosurveys. First, because it wasn't known that people would get vaccinated and that their immunity would fade and they would need another vaccine. So early on, there was a lot of investment in ramping up places that could do repeated serosurveys. And since then, repeated serosurveys through multiplexing have become, a real thing with a lot of investment going into them. And I think one of the best things that came pre-COVID in the NTD space was the WHO set up the NTD Diagnostic Technical Advisory Group. Now we have something like 16 published TPPs, more in the making. Several of them are addressing either the post-MDA or the post-EPHP or the post-elimination of transmission phase of what we're all striving for by 2030. And there's been, because of those TPPs, an incredible amount of investment in biomarker discovery, biomarker qualification, validation, to be able to have the tools that would have, for example, a rapid serologic decay, so that if a positive serology test is positive, it might mean more recent infection than an infection many years past. And I think that it's an area where the Gates Foundation, and I know many others, I think USAID and others, are really investing in making sure that we have those tools, and we don't need to also be, as an NTD programs, paying for the equipment, the maintenance, and the training on that, because it will already be there. We just have to be able to deliver the biomarkers on those platforms that will help us in our use when those surveys are done, whether they're malaria information surveys, HIV information surveys, et cetera. So I just want to make sure that we're also thinking about how we can leverage the pandemic preparedness platforms as NTD programs, and not always how can we help in an emergency response as an NTD platform.
Yes, thanks, Jordan. Very good point. I think we have Pamela Mbabazi in the other room. Pamela, is your hand up?
Thank you very much, Mr. Chair. We were about to all call out in chorus. I also just want to mention that Antonio had a point earlier, but he stepped out. So maybe if he's given an opportunity tomorrow, he may make his comment. First, I want to really thank all the colleagues from the regional offices who've really shared with us a lot of information, both from the presentations they made this morning and this afternoon, and also what the partners were able to share with us. And I will call out, I'll just mention the stack difference. One stack difference I noticed in these presentations is that there was quite a strong reference to the roadmap and the companion documents in the efforts and presentations that the partners were making. While also the colleagues shared with us their presentations that showed a lot of progress in terms of disease-specific indicators and some other work they've been doing, but with not as much emphasis on what the roadmap and the companion documents have actually stated. And this made it very difficult to synthesize all this information in a manner that's comparable. And I believe Dr. Yeshna from Ethiopia, when he said there's a lot of information that's difficult to compare across everything that we've been hearing today. So when we come to actually thinking about putting all this together in a manner that would help us be able to better track and understand, one, recovery with all the disruptions we've had mentioned based on the disease-specific program information we've had today. I would like to remind that we have these indicators that are well clearly presented in the monitoring and evaluation framework of the NTD roadmap and the sustainability frameworks that speak to indicators that are overarching and cross-cutting. I believe that while the disease-specific information is able to show us disruptions, I think subsequently going forward, we should make more effort in trying to reflect all these initiatives, innovations, and efforts that the countries themselves are doing, the regions are doing, and use the cross-cutting and overarching indicators to speak to these things. Because to be able to not only recover in a disease-specific manner, but also align those efforts with the NTD roadmap paradigm shifts that are calling for program acceleration, which we need to do because the programs are disrupted, which are calling for integration and mainstreaming, which is what the indicators are asking us to track, and also for country ownership, which some of the presentations have also aimed to highlight, and innovation efforts. They are indicators to do this. So I would really hope that in the subsequent discussions or meetings and work that we do, we use these indicators that have already been defined by the community and are published to show all the wonderful work that's been presented today in a manner that would make it easier to synthesize and be not only just comparable between countries and regions, but also have a better grasp on where it is we are heading as we move towards 2030. Thank you.
Thank you, Pamela. Jordan, is that an old hand? Yes. Okay, well, I think we've been given a lot to think about overnight. So unless there are any more, don't see any more hands raised. So I think it's time to go for the reception. Where is that?
No, I think it's just a comment to you.
Yes, sure.
So, no, it's
okay.
By email to you so that.
Okay, so we have our wonderful rapporteur, Lucille, and I guess, while we're thinking overnight, if we come up with any recommendations, should they send them to you, Lucille? Or
Yeah, I think we've captured most things from today, and we'll review and revise them tomorrow. But if people have anything that comes out of today's discussions, please share them. I think Daniel, Sol, and I will capture them.
Okay.
All right. That's fine.
So how should they share them, though? Should they
email
in the morning? Email
yes,
you?
or just in the morning. Come across.
Okay.
Okay. That's reasonable.
Excellent. Thank you very much. Good. So where are we going now?
Okay, so I think we have the Linda is downstairs. Yeah, so we're all invited to join us in the cafeteria. It's just downstairs where I think most of you had your lunch. Is there a section for us? Okay.
Yes, there is a section for us.
Okay. That's the ghost voice.
We're gonna help